Good morning, good afternoon, and in some cases even good evening, and welcome to this event on the first ever State of the World's Nursing Report, Unlocking the Gender Dimensions. I'm Sarah Barnes, and I will be your moderator and your host today for our discussions. I direct the Maternal Health Initiative, and I'm also the Women and Gender Advisor at the Wilson Center in Washington, D.C. For those of you who are unfamiliar with the Wilson Center, the Woodrow Wilson International Center for Scholars was chartered by Congress more than 50 years ago as a living memorial to President Woodrow Wilson. The Wilson Center serves as a critical source of nonpartisan foreign policy research and analysis for Congress, administration officials, the private sector, NGOs, and beyond. The Wilson Center also serves as a vital role of connecting Washington with the world. And just like the rest of the world, we at the Wilson Center have had to learn how to work slightly differently over the past several weeks. And I'd just like to take a moment to say thank you to my Wilson Center colleagues, particularly those on the AV team who have helped us transition from having public-facing forums to this online platform. Thank you very much. I would also like to take a moment to thank my colleagues and friends at Jhpiego for their partnership and for their generous support, which has made this event possible today. So the year is 2020, and it is a year that none of us will ever forget because of the COVID-19 pandemic. The year 2020, as designated by the World Health Organization, is also the year of the nurse and the midwife, and was meant to be a year of celebration and much due recognition of these two incredible professions. And while we haven't had the global celebrations or high-level meetings yet, I will say that we can't deny that there hasn't been a global surge of appreciation, recognition, and even awe for the role of nurses, as nurses are so often the first line of defense against infectious diseases and disease outbreaks. My hope, and I'm sure all of you who are listening today are continued support. We're all hoping that this immediate response to the way that nurses have battled COVID-19 will continue and manifest itself into real changes and improvements for nurses and the nursing profession as a whole. I also think this report, the first ever State of the World's Nursing Report, will also help in that progress. Globally, there are almost 28 million nurses. And when you add the 2 million midwives, these two professions together make up 59% of the global health workforce. 59%. It's incredible. And I don't want to take too many findings from the report or statistics because I know our panelists are eager to share. So I will just say that the vast majority of nurses and this global health force are indeed female. So that is why today we have this incredible group of panelists to speak about the report, about the nursing profession, also nurses' response to COVID-19, and how gender is inherently intertwined in all of these things. Today, our panelists are from Nursing Now Global Campaign, the World Health Organization, Johns Hopkins School of Nursing, the International Council of Nurses, and Jhpiego. Thank you all for taking the time to be with us today. For those watching this webcast online, and we've heard there are quite a number of you, so thank you so much for joining us. You can be engaged in the conversation by sending questions for our Q&A period for the panelists. Please send an email to MHI for the Maternal Health Initiative, MHI@wilsoncenter.org, and we will get those questions to our panelists at the end of the program during a Q&A. So please include your name and your affiliation and your question in those emails. And again, it's MHI@wilsoncenter.org. You can also follow the conversation on Twitter with the hashtag #StateOfTheWorldNursing. To start us off today with opening remarks, we have Dr. Leslie Mancuso. Leslie is the president and CEO of Jhpiego, an affiliate of Johns Hopkins University. In addition to being a recognized international business leader, Dr. Mancuso is a nurse and an American Academy of Nursing Fellow and a passionate advocate for the nursing profession, lending her expertise to the Advisory Council of the Johns Hopkins School of Nursing, as well as Sigma Theta Tau International's visionary Global Advisory Panel on the future of nursing and midwifery. I turn things over to you, Leslie.
Muted. Thank you, Sarah. Thank you so much for your kind introduction. Well, it is truly an honor to be here today to celebrate the first ever State of the World's Nursing Report and the heroic nurses whose work it illuminates and whose needs it shows very clearly. Now, I first want to take a moment and thank the Wilson Center for working so closely with us on this. We've had a wonderful strategic partnerships over the years. It's truly special to work with the team at the Wilson Center. I also want to thank the Johns Hopkins School of Nursing, as well as the Frontline Health Workers Coalition for their support of this event. Well, as anyone that knows me knows, I always say that I am a nurse first and I am a nurse foremost. And I have accepted other titles people have given me: businesswoman, entrepreneur, advocate. But my passion for nursing today is as strong as it was when I began my nursing career in 1978. Now, all of us at Chapago were so honored to be part of this inaugural report, working with the International Council of Nursing, the World Health Organization, Nursing Now, and the School of Nursing at Johns Hopkins University. All of us felt very strongly that this was an extraordinary opportunity for all nurses around the world. Now, the launching of this historic report happens at a very historic time, when the world is confronted with a pandemic that is challenging all of health systems, from Los Angeles to Nairobi. And thus, that's why we're doing this meeting virtually. When we debated whether to do it, we resolved ourselves to say that we were going to do it virtually because we wanted to honor the nurses that right now, as I'm speaking to you, are working under the most challenging of circumstances. Today's global crisis has forced communities around the world to see something that we as nurses already knew: that investing in nursing is critical to ensuring the health of all people everywhere. Now, as the world is so gratified and so pleased with seeing the role of the nurse who is risking their lives to save and protect others, we must recognize, and they must recognize, that in order to truly appreciate nurses, they must support us, they must invest in nursing, and they must protect nursing. Now, this report gives us the roadmap to address just that. It gives us a roadmap to look at investments in nurses as individuals and look at creating new jobs and look at investing in nursing leadership so that we can, in fact, reach universal health coverage and protect the nurses that we so value. The report highlights many items, including that governments must invest in massively accelerating nursing education. That's students, that's faculty, that's infrastructure. And at the same time, they must create jobs for those nurses that are educated to go into. It's truly been something that people have underappreciated, the relationship between jobs and education. The report also highlights an investment in accelerating 6 million new nursing positions, particularly for low and middle income countries. And that's to offset the shortages and also to further progress according to and trying to reach that universal health coverage. The third area highlights investments in nursing leadership, really trying to address that new changes of models, looking at advanced practice nursing, looking at policy and decision-making, so we can more efficiently and effectively change the health and social care systems. Critically, for the first time, we have data on nursing that allows us to look at the country's healthcare infrastructure and workforce. It allows us to see their strengths, it allows us to see the challenges, and it allows us to see the opportunities for improvement. 191 countries out of 195 countries produce data for this report. Now, that is truly remarkable. But what's also remarkable is the data that countries were unable to provide. data around entry-level wages, around rates of deployment, and as well around educational expenditures. The report's findings also very much highlighted the need for decent working conditions. It is futile for us to create new nursing positions if there aren't employment opportunities and decent working conditions. For a profession dominated by women, we must make progress and pay equity. We must have auditing of hiring and promotional practices, and we must ensure that policies are followed around prevention and addressing sexual harassment and violence in the workplace. Future policies must also consider an enabling working environment, particularly with a profession that has 90% women in it. They must look at flexible and manageable working hours. We must have a gender transformative leadership development program for women in the nursing workforce. And we must have equal standing and playing field in pay and practice so nurses can stand side by side with their contemporaries, regardless of gender, degree, or wages. I'm eager today to learn from a fantastic team of panelists about the intersectionality of gender with other issues, including migration. One thing we learned in the report is that 1 out of 8 nurses work in places where they weren't born or they weren't trained. And this brings a whole constellation of other considerations we must make. Now, we are living in unprecedented time. And we know that when this COVID crisis ends, the world will have seen, communities will have seen, that nurses were the cornerstone of this pandemic. The State of the World's Nursing Report was clear. Nurses need to be able to function at their full scope before, during, and after emergencies, and they need to be able to protect themselves and their families. Together, nurses have the power and the influence to handle many crises, whether that be a pandemic or HIV/AIDS or non-communicable diseases or many other areas. As individuals or members of an interprofessional team, they are the backbone of the health system, both here in the United States and around the world. Nurses provide 80% of healthcare services around the world. We are 28 million strong in the world right now. We need broadly educated leaders in nursing that can absolutely identify and analyze problems, develop solutions, and act. We need nurses empowered that can demand a seat at the table to make decisions and provide quality, patient-centered care for all those that need it. There should be no question right now that investing in nursing saves lives and saves livelihoods. Now, I have been in awe, and I've had so much admiration for the determination, the bravery, the skills, and the resiliency of nurses we are seeing on the front line now around the world. What this report does is allows us to look at the role nurses will play in the world at large moving forward. Nurses will influence, and we will not have universal health care without nurses, and we will not have primary health care without nurses. So the report focuses on what we need to do in the generations moving forward. We need to have more data collection. We need to have more advocacy. We need to have more policy dialogue and how to put things into place. And we need to invest in the health workforce around the world. Thank you.
Wow, thank you, Leslie. That was tremendous, and I'm feeling a little emotional. That was really exciting, and thank you for sharing all of that information with us and getting the rest of us excited and ready to speak as panelists. So that's who I'm going to turn to now as our panelists. And our first panelist is Jennifer Breeds. She's an actively practicing nurse and gender advisor at Jhpiego. Jen is a member of the core team at Jhpiego that was contracted by the WHO to support the development of this landmark report. So Jennifer, you and your team have been engaged in the data reporting and report development process with partners since as long as last summer. Can you share a brief overview of what this process was like and how gender and nursing are intertwined?
Well, thank you, Sarah. And as you mentioned, JPIGO is pleased to play a supportive role, not only in developing the report, but also in supporting governments in the months ahead to make important policy choices and take action around the findings. And, you know, when I think about this moment, it's almost hard to fathom that until now, there's never been a global snapshot available of the world's largest occupation of health workers and one that's predominantly women. So it is very, very exciting and meaningful to have this data available in this report to be able to act on. So speaking to the process of data reporting, I think it is important to establish upfront, this was very much a government-owned and led process within countries. So JPIGO worked through each of the 6 WHO offices to help countries report into the National Health Workforce Accounts, which some of you might be familiar with, but in case you're not, it's a system that was adopted by member states during the 2016 World Health Assembly for countries to begin to progressively standardize and improve their health workforce data for all occupations of health workers, including nurses. But as the first professional group to be able to fully leverage this NHWA system to inform a global workforce report, nursing had the exciting opportunity to be trailblazers and to lead the way in using the system and its indicators and in forging relationships, opening up new channels of communication and coordination with intersectoral ministry officials, and also with appointed NHWA focal points in their countries. And so because of this, the data presented in the report is more robust than what's ever been previously available at the global level. And it comes directly from country sources. It's not imputed. So I won't go into detail on each of the 30 indicators that were carefully chosen by the steering committee to be included. I'll leave that for you all to read more about. But in a nutshell, some of the questions the data does seek to answer include who nurses are in terms of their numbers, their age, gender, where they practice, basic description of their education, if regulation exists in their countries around their practice, around their working conditions, working hours, and also what their access is to leadership programs, to fair wages, advanced practice roles, and much more. So I do want to point out that importantly, country level data is also publicly available online and being regularly updated so that nurses themselves, nursing leaders, policymakers, donors, all of us tuning in today can continuously access and importantly use this data. And we don't need to wait for the next iteration of a State of the World Nursing report to arrive in order to track our progress and changes in responding now to the findings. And so, you know, as Leslie pointed out in her powerful opening remarks, while the data presented is impressive and telling, so too are the gaps in terms of what was not able to be reported yet, particularly around entry-level salaries, educational investments, labor market flows, and gender wage gaps. So given that up to 90% of the nursing workforce is female, these omissions are inherently gendered, and they also underrepresent women's contributions to the global economy. So my takeaway from this process is that just as important as the report itself is the tremendous momentum that's really been set in motion over the past year by using the NHWAs and meaningfully engaging nurse leaders as partners with governments in gathering, triangulating, validating, and now importantly, acting on the data to drive change. And that includes around the gender dimensions that this report brings to light and that we'll be importantly exploring more together today on this panel.
Thank you so much, Jennifer. So now we're going to turn to our next speaker, who is Emily Katirikawe, and Emily was trying to connect from Uganda. Emily is the Uganda country director for JPIGO, where she provides oversight and programmatic leadership, fostering innovative approaches to health system strengthening. Her experience includes managing complex public health programs and building the capacity of local organizations. Emily was also involved in supporting the Nursing Now campaign in Uganda. And she was on with us a little bit earlier, but I think that the connection has just been very difficult, and even getting into a space where she'd have proper Wi-Fi was quite limited due to COVID-19 and not being able to be out. Oh, but I see her right now. Let's see if she's coming through. Oh, I think I lost her again. Emily, can you hear us? Hi, Emily, I can. So I think, oh, Emily, can you hear us?
I can hear you, but I'm trying to use my phone and it's not working that well. I don't think it will use the camera well.
That's okay. Why don't we just skip the camera? And if you just can give some comments just using the microphone, then we'll skip the camera part, and I'll share a screen with some of your information on it. But as you may have just heard, hopefully the connection was okay. Jennifer gave us kind of a global look at the report. And so now I'd like to hear, what some of your experiences are in Uganda regarding nursing and gender, and the importance of this report to countries, Uganda in particular. Are you there, Emily?
Thank you very much. I hope everyone can hear me. My name is Emily Katarikawe. I am the
Emily?
And I'm happy to be part of reading this report. I wanted to share about. Hello, can you?
Okay, everyone, I just got a message from Emily that she really is having a hard time connecting, as you could tell, and asked us to please just share a video that she recorded. So let me put that up right now. Just takes 1 second.
Ladies and gentlemen, it's an honor to be part of this great panel that is discussing the State of the World Nursing Report. My name is Emily Katarikawe, Country Director, JPIGO, Uganda. I want to take this opportunity to thank all of you who worked hard with this report together that brings out key issues affecting the nursing profession. In reading this report, 3 things stood out for me. First, the gender inequality in the global composition of nurses. It is very clear that the nursing profession has followed stereotypes associated to some professions. The minimal presence of men in the profession in the developed world indicates how this profession is perceived. In the low and middle income countries, nursing seems to look like the second-class choice for those who have not made it to the professions of their choice. This mindset undermines the nursing profession, and it is time to push and advocate to ensure that men see nursing as a career opportunity and a profession of choice. The second issue that came to me was the equity and protection within the workplace. There are disturbing indications of existence of pay gaps where female nurses are paid less than their male counterparts. The disparities in remuneration are not acceptable and need to be explained, and we must work to ensure that nurses are protected from such unfair decisions. There are also serious concerns that nurses, though they make up approximately 6% of the health workforce, they do not have at least 10% of leadership position in the healthcare system. In my experience, nurses demonstrate leadership qualities every minute in their workplace as they work to save our lives. It is these qualities that we need to nurture intentionally and make sure that nurses are given the confidence and space in the boardrooms and at the decision-making tables. Absence of protection from attacks in the majority of countries is also an issue of concern. It is urgent that we advocate for integration of the right policies globally. Nurses are parents, nurses are spouses, they are providers and caregivers. Nurses remain the heroes we have in tough times like we are in today, and they need our support. I thank you.
Thank you very much, Emily. Hopefully Emily will be able to join us again later for the Q&A. So now we're going to move to Barbara Stilwell. Barbara is the Executive Director of the Global Nursing Now campaign. For the last 25 years, she has worked on international health workforce issues and has helped countries around the world manage change and development in their own health workforces. In the UK, Barbara is best known for introducing the nurse practitioner role in general practice. Emily spoke a bit to this already in her video, but I'd love to hear from you what you see as the value of the State of the World's Nursing Report to countries, and why is this report such an important part of the work of Nursing Now?
Thanks so much, Sarah, and thanks for having us on this panel this afternoon. We're extremely pleased to be here and to have the opportunity, and recognizing that we are all challenged from where we sit at the moment in participating in things. I think for us, one of the most exciting things about State of the World's Nursing is that we finally all around the world have evidence and data. Sorry, terrible pollen count here. You perhaps have it in America too, making me croaky today. We're all finally on the same platform, data platform, regarding nursing. There are lots of things about nursing that nurses, and those of us who've been nurse researchers and nurse developers, lots of things that we've known. But now we've got the data, and not only the global data. If you go onto the WHO pages, you can see your country data too. And this is a huge opportunity for nurses to do something that they don't often do, in my opinion, not often enough. And that is to look out from nursing and tell other people about what's going on in nursing. So we know that now, 90% of nurses are women. You know, we always suspected that that was the case based on what we see and our experience, but now there it is. We have this. And We also know that women who are nurses don't hold leadership positions. They tend to be held by men. So last year, Nursing Now, with Johnson & Johnson and IntraHealth International, we actually did a survey because, you know, we realized that we were promoting, Nursing Now was promoting leadership training for nurses. And some of our intel was saying, well, there's plenty of leadership programs for nursing, but we just don't, for nurses, and we don't see nurses, particularly female nurses, assuming more leadership positions and in huge greater numbers. So this was something that was of interest to us, and we did a survey together, and actually that survey also informed some of what WHO have reported as well. But what was very interesting was that some of the softer things we found were that nurses do not feel comfortable going into a big meeting, nurses who are women, and speaking, especially when many of the people in the room are men. And they told us this. They feel intimidated and they don't feel confident in using data. So that's another reason why we're saying nurses need to find a voice, particularly nurses who are women. And we know that nurses who are women face the same constraints as women in other occupations, in that there's a glass ceiling. And though nurses may become senior managers in nursing roles, they often don't get into the wider managerial senior level positions, which they could and are qualified to occupy. And one example of that from the UK is Director of Public Health, and there are lots of nurses who are experts in public health, and it took many years for there to be a recognition that nurses could be directors of public health. You didn't have to have a medical degree, you had to know about public health. So, you know, there are lots of those positions around the world, and I think this report actually gives us data. It gives nurses data that they can find a voice with and take and present as a manifesto to their policymakers, politicians, budget holders. It's no longer just, well, I feel we're short of staff, I think we need more nurses on this ward. There's data. You can actually take it, you can put it in a graph like Florence Nightingale did, and you can take it and show it and make your case for being given more resources. And that's exactly what's happening now, where we see nurses advocating for more resources to help them deal with the pandemic, based on what they're dealing with, and they're actually able to find a voice. But what we also find is that nurses need encouragement to speak outside nurses. Nurses love talking to nurses, and they're very, very good at that. But what we need to do is to bring into our meetings, our conferences, all of the things we do, people who aren't nurses. Not only physicians, but policymakers, managers, politicians. We need to get them interested. And you may have noticed that our Prime Minister, having been in intensive care with COVID-19, we're all very relieved that he's better. The two people he called out were nurses, as if he'd never noticed there were nurses before. So we're trying to get hold of him and say, look here, you know, this is the year that you need to be investing in nursing. And now you know why.
Thank you so much, Barbara. And then now we are going to move to Michelle Macisaac. Michelle is an economist and health workforce specialist at the World Health Organization. At the WHO, she leads the program of work on gender and equity in the global health workforce, where she works to address gender inequities in the health and social workforce itself. She co-chairs with Women in Global Health, the Gender Equity Hub. So Michelle, in order to support nurses and increase the numbers of trained nurses, which several people have spoke to already, the need for this, what does an investment in nursing in the health workforce look like?
Thank you, Sarah. And thank you, Leslie, for setting the stage, and Emily from Uganda for giving us a taste of what it might feel like to be dealing with some of these things every day, and Barbara for bringing us back to earth and talking about the need not only for data, but for an understanding of the qualitative and the emotions that go into driving what we have, and maybe some of the why as to why we're seeing some of the numbers that we're seeing coming out in the State of the World's Nursing Report. So for thinking around investments, WHO has been working since about 2016, really talking about the global health workforce shortage in general, and the need for countries to really be thinking about investing in health workforce and ensuring that we have sufficient supply of health workforce for things like COVID-19 and then emergencies that are happening. And so we've been talking about this for a while now, and the State of the World's Nursing Report gives us a really good bird's eye view on what's happening in one of the particular health occupations, nursing, which comprises the vast majority of health workers across the globe. And so for us, really what investment looks like is we're looking at something for sustainable domestic, regional, and international investment. And this investment is going to come in through three pillars. It's going to come in through education. We're going to see some jobs, decent jobs creation, and then in leadership. So we think that the investment needs to really have these three dimensions to it. At the moment, what we know is that there's a global shortage of almost 6 million nurses across the world. So we definitely need to see some investment for education and training to increase the supply of nurses, to fill the gaps. But also we need to ensure that we're creating jobs, because those are the things that are actually going to fill the shortage that we're seeing. It's not sufficient to just increase supply. We have to see the supply being used in the right ways in the right places. Based on the calculations of the State of the World's Nursing Report, we know that countries who are experiencing a shortage will need to increase the number of graduates, so increasing the supply on average 8% every year through to 2030. So this is an estimated cost for these countries of around something like $10 per capita through to 2030 to really get us up to the level that we need to see redressing this global shortage. So there clearly needs to be this investment, particularly in nursing, but we also need to see this encompassed in a greater investment in girls' education and pipeline that feeds girls into professions like nursing. So we want to see more investment in STEM education for girls, ensuring that girls from all backgrounds who have the desire really to enter nursing are able then to meet the requirements to get a place in a nursing school. So the general investment in nursing faculties is needed, and research is needed for nursing, so that the nursing schools will have the capacity really to deliver the increase that we're going to be needing to see in training over these next decade. We need to see investments in nursing infrastructure and clinical placement sites and accessibility to increase the number and to increase the diversity really in graduates that we're seeing coming in through nursing. The solution is not just investment, obviously, in education, as has been alluded to. The world can't simply train more nurses and expect this gap to be filled. It's really a lot more complex than that. In some low and middle income countries, what we see is that we have nurses who are having a hard time finding decent jobs. So what we need to see happening in countries is, on top of this investment in nursing, is a look into the reviewing of fiscal space to employ more nurses. So how are we able to absorb the nurses that we're producing? That some countries will really require to look at the relationships with international financing institutions and as well with development partners to really redress this gap. In addition, the jobs that are created need to follow principles of decent work. So we don't want to just have nurses having jobs. We want nurses to have good jobs. We want nurses to feel satisfied in their working roles. So we want to really ensure that the conditions are good, that they're well paid, and that they come with protection from violence and harassment. And we know that violence and harassment in the health sector is high. It's much more prevalent than we see in other sectors. So it's really important that nurses are taken care of when they are in the labor market. So we want nurses to be valued for the work that they do, and that others who are looking into the nursing profession find this to be an attractive place to go, and that nurses who are already there find this an attractive place to stay. It's clear as well that creating decent jobs at an aggregate level is not going to be sufficient. So we have as well a distribution problem that needs to be addressed. What we know is that about 90% of this shortage, this almost 5.9 million shortage, is in low and lower middle income countries. So even in these countries where we see shortages, those shortages are not uniform across geographies. So we see that sometimes in rural areas or in the poorer areas of countries, that this is really the places where jobs for nurses need to be created. And indeed, those kinds of investments are going to have to be tailored to those communities and those contexts. So we have to take this with a grain of salt as well. We want to see that, and when we say sustainable investment, what we also mean is inclusive investment. So we want to see investment in nursing leadership positions. So we want to see nurses coming to the forefront and having a seat at the table in all of the decisions that we see across the sector. As such large numbers of those pervading the services, it makes only sense that they're actually there at the decision-making level. And the other thing that we want to see some investment in is around the filling of the knowledge gaps that we have, right? So the evidence based on which we can help advise ministries on investments have some gaps in them. And so we really want to see that this data capacity, the data reporting and the evidence base increases so that we can make the right evidence-based choices and that we can do the kinds of analyses that can really help governments to make evidence-based decisions. So for us, this is the sort of the tip of the iceberg, as they say. There's so much more that we need to be thinking about and complementing this as we go forward. So thanks for the opportunity to be here.
Thank you so much, Michelle. And last but definitely not least, we turn to Rosemary Morgan. Rosemary is on faculty at the Johns Hopkins Bloomberg School of Public Health with a joint appointment in the School of Nursing, where she researches gender and health systems. She's a member of the Gender Equity Hub of the Global Health Workforce Network and co-coordinate of the International Gender and COVID-19 Working Group. Rosemary, can you speak to the gender nature of nursing in relation to health systems a little bit more broadly? Thank you.
Great, thank you. And thank you very much for having me here today. It's an honor to be part of such an amazing panel with such great speakers. So I am based at Johns Hopkins at the Bloomberg School of Public Health, where I predominantly, research gender in relation to health and health systems. And the human resources for health, and in particular nursing, is a really big part of that. And what we know from the data and from research is that health systems themselves are gendered institutions. So the same systems and structures of marginalization or oppression that we see in society, such as sexism, racism, patriarchy, we also see these reflected in health systems. These structures influence what services are provided, what is included or excluded in insurance packages, for example, what is included and excluded in policy, what policies get made in the first place, and who is included or excluded from decision making. And what we often see in health systems is a focus on health systems outcomes, so like health outcomes, improving the health of the world, of the population, but we often don't see a lot of discussion in relation to the systems themselves and how they might be inequitable and might be perpetuating inequities. And we argue that how can we expect equitable outcomes, equitable health outcomes, if the systems and structures which support that are not equitable themselves? So we know that the health workforce is extremely gendered, and we heard a lot of great examples from the speakers today already. We know that women make up approximately 70% of the global health workforce in general. And with nursing, this number increases to 90% in some contexts. And the State of the World's Nursing Report really does shine light on some key gender dimensions of the nursing health workforce. It's interesting to look at the sex-desegregated data that it showcases. The report states that in some contexts, such in Africa, the women make up around 76% of nursing, while in other contexts, like in Western Pacific, it could be as high as 95%. And we see all of this average at about 90% of nurses worldwide are women. So professions that are highly gendered, like nursing, and skewed towards women's representation are often undervalued. And this links back to the systems and structures of oppression that I mentioned before, sexism and patriarchy. You know, and we see this undervaluing in relation to pay scales, who gets paid and how much. We saw a great example earlier about nurses, female nurses not being paid as much as male nurses in some contexts. We see this reflected in leadership structures, who progresses into leadership positions at all and who is left out. While 75 to 90% of the nursing workforce is women, we don't see this representation in nursing leadership positions. So men who enter nursing have a sort of glass escalator effect to nursing leadership positions. And we also see an adequate representation of nurses themselves within national and international decision-making bodies. And we argue that this is because of a general undervaluing of this very gendered profession, which really limits nurses' opportunities to participate in decision-making and be leaders within healthcare systems and structures. So this undervaluing also affects whose needs are taken into consideration and whose are not. This goes back to the policy element. How can we have we need equitable structures within the system itself if we want equitable outcomes. Do we have flexible working hours? What are the working conditions like? Are they decent working conditions? What is equipment that's available or not available? Do sexual harassment policies exist or not exist? And because the nursing workforce is predominantly made up of women, you would expect to see a working environment that is conducive to the needs and lives of women, but that is not always the case. We don't always see that. You know, this also affects whose safety is given a priority. The report itself states that only 37% of countries reported measures in place to prevent attacks on health workers. And we know, as we've already seen, health workers are predominantly female. And only 30% of countries have measures in place to protect health workers from physical and sexual attacks. We see this in relation to discrimination and harassment. A 2019 World Health Organization report delivered by Women Led by Men found that there's often a greater burden of discrimination in jobs where women are in the majority. So 36% of nurses in one context reported that they were not being respected by their seniors, while 32% of nurses said that they would like to be heard or listened to more. And sexual harassment is also a huge issue, and it's faced by women across the health workforce, and about 25% of nurses report sexual harassment and 37% of midwives. It is also really important to reflect on how gender intersects with other social stratifiers and how this affects individual nurses' experience within the health system. We know that gender intersects with race, with migrant status, with age, and it is so important to take this intersectional lens when exploring gender dynamics of the nursing profession. So who gets to become a nurse at all? Who has the opportunities? Who has the opportunities for career advancement and leadership? Are there different working conditions and decent work depending on a nurse's individual identities? We know that migrant nurses are particularly at risk of not having decent working conditions, and migrant nurses and nurses from ethnic minorities are at a higher risk of work-related injuries and discrimination than nurses from the destination country or from the ethnic majority. And discrimination is reported as the leading cause of impaired health amongst migrant and minority nurses. We also see this reflected in leadership structures. Research from colleagues in South Africa, for example, looked at the intersection of nursing, so professional cadre, with gender and with race, and saw distinct experiences of Black women nurses compared to white women nurses. And so these considerations really need to be taken into account. And the report does a really great job of bringing in some of these gender dimensions in relation to nursing and what we really need to pay attention to. Thank you.
Thank you so much, Rosemary. And as you were speaking, I was thinking, if you're not already, or someone else at Johns Hopkins School of Nursing isn't already teaching a class on those exact topics, would be a good idea. Very, very interesting stuff. So now that's all of our panelists for now, and now we're going to have open general questions to the entire panel. But I also want to remind people who are watching the webcast, you can send questions to mhi@wilsoncenter.org. And then in a few moments, we will share those questions with the panel and have continued conversation with you actively who are watching the webcast. For now, what I'd like to do is turn things over. Everyone spoke quite a bit about the report and some of the findings, and I think some of the issues that come top of mind from the conversation are issues with pay equity, sexual harassment and violence, education, leadership roles, investments in nursing, data collection, working conditions and safety, and work retention and shortage. And so now I would like to ask the panelists, and anyone can chime in. So panel, I know it's a little bit trickier when we're in the virtual platform, but please feel free to just unmute your microphone and hop in with some commentary. But I would like to hear some of your ideas on solutions to these problems. Now we have a picture of what the issues are, and there's plenty, but what are some solutions? And I know some of you already spoke to some of these, but I think that that's really a valuable part of the report as well. So feel free to unmute and join that conversation and give me some of those solutions. Thank you.
Thanks. So I think this provides kind of a nice context a little bit. Rosemary talked about a report that WHO put out last year in March called Delivered by Women, Led by Men. And in this report, we kind of focused on 4 key areas. And so I think that some of the solutions fall into these kind of four areas, and I think it applies to nursing as well. So one of the areas was around gender segregation and some of the issues that come around gender segregation. So Rosemary really talked about the high proportion of women in nursing and how this might change the dynamics, how that might affect the labor market outcomes, let's say, of nursing. It might affect how nursing is valued by society, how it's paid. So occupational segregation is really important. Barbara really talked about the leadership. So why are we not seeing more women in leadership roles when we're seeing women so prolific in terms of service delivery? So that's another area. So occupational segregation, pay gaps are another area. So what we often see across the health sector, and indeed actually what we see in the health sector, is that pay gap, because of the high levels of occupational segregation, where we see women segregated into the lower paid roles and men tending to be in the higher paid specialist roles, is it actually has a higher average occupation or a higher average pay gap than other sectors. This changes a lot when we look at each individual occupation, but overall it's really important to talk about the pyramid, essentially, of power in the health sector and among health workers, and how that's driving a very large gender pay gap. And then the other one is decent work and working conditions and sexual harassment, which we know is very, very high for health workers. And then there's a gender component to that as well, right? So I think that what we know, or what we think we know about it, is that that the different kinds of violence or harassment that health workers face is dependent perhaps on their occupation and perhaps on their gender. Across the board, health workers are experiencing high levels of these kinds of harassments and violence, but maybe what we might know if we had this kind of data is that nurses might be experiencing a different kind of aggression. Maybe it's an internal aggression from the hires within versus the external. So it's really important that we kind of look in very closely to understand what gender aspects are driving the violence and harassment levels that we're seeing. So there's a good start, I think.
Great, thank you. Barbara, go ahead.
Yes, I agree. That's a great start, Michelle. And thank you and Rosemary for pointing out the gendered systems, which I think, is something nurses have to face. There are 3 things I think that we're an advocacy campaign. So of course, we focus a lot on what we can advocate for. One of them I mentioned, there are 3 things. The first is one I mentioned, which is I think we can look at what jobs can be open to nurses. And, they're often jobs that are segregated by, in the health sector, like this is a job that can only be done by a doctor. And actually that's often not true. And one example of this, which I'll say very quietly and don't tell anybody I said it, but one example was WHO. Where they've had a lot of jobs that have been advertised for doctors that actually now, because of some advocacy and pressure, it's beginning to change, and they're open to more people. And that affects this very sort of complex and rather soft aspect of some of what we're talking about, which is the way nurses are perceived. So I think that's very important. The second thing is similar in a way, but it's to do with research findings. Now, nursing has got to be one of the most researched professions in the whole world. I mean, when I was working as a nurse practitioner, everybody wanted to look at what I did. Was it safe? Did I kill anybody? You know, could I do this, that, and the other? Nobody looks at other professions like that. It's nurses that get under this particular microscope. But one of the things that that's resulted in is a lot of evidence about what nurses can safely and effectively do, including deliver 80% of primary health care. And yet, policies don't reflect that. So in England, for example, Nursing Now paid a visit to the Minister of Health and, among other things, was talking about the effectiveness of primary health care. And the next day, he was on the television saying that he needed to recruit more doctors for primary health care. So there's clearly something about the way we deliver messages that is less than compelling. And, you know, we need to be learning from people who do that effectively, like people who advertise. How can we make that better? How do we put our case in a way that's really compelling? Because it does have, it's not just our opinion, you know, these are research-based findings. So how can we actually do that? And then the third thing is about what we've been talking about is you know, get nurses, women nurses in leadership positions. They're promoted without a budget. And this is what we found in our survey, the IntraHealth J&J Nursing Now survey last year. Nurses get promoted without a budget or without budgetary discretion and with no team. So they can't do anything. So at the end of the year, you know, you've promoted a woman into a senior position, you say, oh, well, you know, nothing's happened. And so we have to be making sure that nurses advocate to when they get promoted, not only for the position, but for the budget and the team, so they can actually get things done.
Thank you. It looks like Jennifer and Rosemary both are going to make a comment to this. And then just a heads up, then we're going to switch the conversation before we lead into the audience Q&A. Go ahead, Rosemary.
Great, just to pick up on a point that Barbara mentioned about data, because, you know, I work in the academic space, and we did a literature review that looked at gender and human resources for health among doctors, nurses, and community health workers. And this was a couple years ago now. And while there were a lot of published articles on gender and nurses, what really struck me about what was out there is there was a disproportionate number of articles on men's experiences within nursing, which to me was really gendered. The fact that this was a topic that people wanted to look at. Like, there was very little on the gendered implications of the nursing workforce itself and the implications for women. And, you know, and it is true, experiences of men in nursing, they have very unique experiences, of course. They're in this very gendered profession. But the fact that the majority of data was on that topic was, I thought, quite highly telling in relation to this, you know, the issue of gender. And I just wanted to quickly draw attention that, you know, in regards to solutions, Women in Global Health have developed a 5-point action plan to address gender inequities within nursing that really touch upon the report. And they also, it links to what the previous speakers have just said. And these include, you know, number 1, include nurses and midwives in strategic decision-making. 2, enable female nurses and midwives to lead themselves at all levels. 3, support diversity in nursing and midwifery. That brings in the intersectional lens. 4, end sexual harassment, violence and bullying of nurses and midwives. We need policy and action to do that. And 5, pay nurses and midwives fairly. You know, and these are 5 sort of key actions that really reflect on the data in the Nursing Now report, in the nursing report that just came out.
Wonderful. Thank you, Rosemary. Jennifer?
Thanks. You know, I think another area that's a very practical area that we can focus on is around scope of practice and truly empowering nurses to practice at the full extent of their education and abilities. And we know that that's often not the case, unfortunately, in these countries, and that the nursing profession is curtailed by a regulatory environment that just doesn't keep up with, you know, perhaps the education or the evolving needs of populations. And so when nurses can practice as empowered members of interprofessional teams to deliver primary health care, I think that can really change the image and the contributions that they're able to make, you know, within from a regulatory perspective, and that's a really important step to empowering the profession. I also was really interested in noting, you know, in the report, 30% of member states still reported they do not have a government-appointed nurse at the helm of the profession in country. So, you know, we do have a need to make sure that, you know, there's an intentional appointment of chief nursing and midwifery officers in 100% of those WHO member states. And as others have said, to make sure that they have the voice and the autonomy and the resources they need to lead. And I think it's, you know, not enough to expect women to lean into professions and organizations that have largely excluded them from leadership and senior roles. And so when we talk about being gender transformative, it's equipping women with skills around the confidence that they need, those tools, also supporting men to help be an ally for women in the profession, but also changing those informal and formal systems, the policies, the conditions, the cultures that, you know, really prevent women from being included, women nurses, on an equal basis to men. And I think we can ask ourselves very practically in the different programs and task forces activities that we're involved in right now, are nurses represented here? We can all do that and ask, how can I make a space to engage a nurse in this effort? And is there a nurse who could speak to this issue in the media? Or is there a nurse who I could mentor or position here for a leadership role?
Wonderful, thank you. Thank you all. I know that we really couldn't have an event today on nursing and this wonderful report without talking about COVID-19. And so I wanted to switch the conversation a bit now to really talk about the nurses' immediate response to COVID-19, and you all can speak to different levels of your engagement in that profession, whether directly or in other forms. I did hope to throw this question first to Emily. It does look like she's fallen off the call. So I will just note that I did read an article yesterday about the incredible success of 13 African female health ministers, who are leading the way in the COVID-19 battle, and Uganda was one of those countries. So there is some extraordinary work happening there in Uganda, and I will find a way to somehow get Emily's story out to people, because I'm sure after watching the video, people will be very interested in hearing more of her hands-on experience and what they have experienced in Uganda since the outbreak of the coronavirus. So now I'll turn this to the rest of you. Another thing that I also saw, another statistic yesterday, was that in the United States, there's 9,000 healthcare professionals have tested positive for COVID-19 as of yesterday, and 73% of those are women, which I guess isn't so surprising given the high numbers of women in these healthcare roles. But I just wanted to allow each of you to speak to the experiences that what you're seeing on the ground or in other areas on nurses' response to COVID-19. Thank you.
I can start. So, as mentioned earlier, I'm helping to coordinate a working group on gender and COVID-19, and we're really interested in exploring the gendered effects on the epidemic, how it's impacting women and men differently, both in relation to health and social and economic and also work environment. And the health workforce really comes into that. And as we've heard today, the nursing makes up such a huge percentage of the health workforce, and they really are on the front line, you know. And in some countries, we are seeing COVID-19 infections among female health workers being twice as much as the male counterparts. So while, you know, we don't have a lot of sex disaggregated data. Countries are not yet reporting on this. So we have to make assumptions on the data that we do have. And the data is showing, for example, while men, the infections between men and women are about similar, men are dying more. But when we look at health providers, the story changes. It flips. More women are becoming infected, and we don't have the mortality data yet to know what the implications of that are going to be. And it is so important that governments ensure that all healthcare professionals, including nurses who are on the front line, have adequate protection against transmission. Sarah gave the data from the US, and we're seeing similar numbers in Spain and in Italy. 72% of the female healthcare workers in Spain infected were women, where 66% in Italy were men. And, you know, what we're seeing from this is that healthcare workers are not being adequately protected. Women who are working on the front lines are not being adequately protected. There are reports of female healthcare workers failing their fit tests, you know, when they have to do that test for the personal protective equipment to make sure that it fits properly. Because the issue is that the reason that they're failing these tests is that this equipment has been designed for the male body, using the male body as the norm or the standard, right? So, and this is a huge issue. We don't have equipment to adequately protect the huge percentage of the workforce that are women. And we know that the viral load, when someone is exposed to the viral load they're exposed to affects the seriousness of the infection. So health workers, in facilities are more likely to be exposed to higher viral loads. So protection becomes so important, and they really must be protected. And we're not seeing that right now.
Thank you so much, Rosemary. Does anyone else want to? Barbara, go ahead.
Yes. Thank you. We've been focusing as a campaign on, we are focusing on compassion, really. So helping nurses to be compassionate to themselves during this. And we found there's actually a huge interest in this. And part of it is to be compassionate to yourself is asking for what you need. And, nurses are often not very good at that. So we're getting them to step up and say, I need breaks, I need meal breaks, I need PPE. And, supporting them to make those asks. The other thing we're finding is that, strangely, or maybe not strangely, but teamwork seems to have become more important. So, nurses as part of multi-professional teams, maybe it's because a lot of the publicity seems to come from ITU, and that, there are many teams on intensive care, respiratory therapists and different specialists and specialist nurses. But it's interesting, at least I find it interesting, that we found a lot of physicians are speaking out for nurses. Which is interesting. And there's also a lot more female physicians who are featuring on the media. However, we have also found that there are not many nurses who are brought out into the top sort of media briefings. It's very unusual. And given that nurses are, really significant in this pandemic, you would wonder why nurses are not more represented at some of those meetings.
Go ahead, Jennifer.
Thanks. No, I just wanted to build on what other panelists have said. And, in terms of talking about responding to COVID, nurses, part of what I love about the profession is how dynamic it is and how nurses practice in so many settings across communities, in homes, in clinics, in hospitals. And so we can really have influence right now in a very large capacity in lending support to community health workers around health education and messaging campaigns around social distancing. Nurses are also really well positioned to respond to gender-based violence and intimate partner violence, which we know is increasing and in fact surging right now. And so, there's specialist nurses, forensic nurse examiners, sexual assault nurse examiners that could play a role, and that we know, and as it was mentioned in the SOAN report, that nurses and midwives are overwhelmingly the majority of those frontline providers that are doing the screenings already. And so we need to make sure that they continue to have the skills and support and tools to respond and to provide that care. And, I think just lastly, it's important, what I hear the most from the front lines and from colleagues responding right now is that really now more than ever, the dual caregiving role that we have as nurses, caring for clients and then caring for families. In most cultures, women still are the primary caretakers and household managers. So their ability to socially distance from their families is inherently different than it is for men. And so we need to think about that in how we continue to respond and make sure that nurses are well supported in those roles outside of the roles that are so important that they are playing right now for patients.
Wonderful, great. Michelle, if you want to just take 2 minutes, and then we're going to move to questions from the audience.
Sure. So I think at the WHO, what we're really wanting to ensure is that there's equitable access to training and to personal protective equipment for health workers. We're hearing lots of stories. I think what Barbara kind of alluded to is there's this kind of 2 layers of stories that we're hearing. And, I think outbreaks and pandemics can really show the cracks in the system. And the systems that, had maybe pre-existing issues in terms of decent work conditions, and we're hearing stories of health workers being very scared. And then in certain health systems that we know that they had really kind of resilient health systems embedded in advance, then what we're actually starting to see is that there's this team building and a lot of resilience, a lot of determination, a lot of team sentiment. We've heard stories of nurses, younger nurses who still feel very fit and energetic, taking the shifts of the older nurses, or other health workers sharing tasks in a way that they weren't doing before. So I think there's lots of lessons to be learned in terms of how each health system as an entity is handling this.
Thank you, Michelle, and thank you all. Now we're going to turn to my Wilson Center colleague, Amanda King, and she's been keeping track of the online questions. So Amanda, over to you.
Great, thank you everyone for sending in your questions. To start, we have a few questions around coronavirus, so I thought that would be a good transition for us. Our first question is from Annette Galassi. She is actually a nurse, and we've talked about the protective equipment issues, and she said that in low and middle income countries, she's seen a lack of job protection for nurses who actually raise issue around the protective equipment available, especially for administering like chemotherapy. And then she said that she's seeing the same thing here in the US, where nurses may be fired around this lack of protective equipment. And even while the nation is facing a nursing shortage during the pandemic, she was wondering how we can shift this position of seeing nurses as expendable and whether the report addresses it, but I would also add how the report could leverage it. And then our other question is from Peter Johnson at Chipigo. He mentions that now that the nation and the world as a whole is seeing this gender inequities around the profession of nursing, how can we, now that we recognize it, how can society act on fixing the problem? And one last clarification, I think someone was just in shock, from Marie Louise Seberg in Oslo. She said, for Rosemary, did I hear that correctly? In a sector where 75% of those are women, in a profession where 90% are women, protective equipment does not fit women's bodies. So over to all of you.
Wow, those are some good questions. So panelists, before you dive in, we only have maybe 10 minutes before we're going to turn things over to our closing comments. So please pick and choose between those questions. And Rosemary, just maybe give a shout out about that last question to clarify the statistic you just gave.
Sure. We don't have a lot of the sort of the sex disaggregated data. We need more data. A lot of the evidence is anecdotal, it is stories, but we do know that in the health profession, medical profession as a whole, and in society as a whole, actually, the male body has been used as the norm for a very long time to create things, to test things. Women have been excluded from clinical trials. Women have been excluded, or, seatbelts are tested on men and put women more at risk. The same goes for medical equipment. And of course, it's not going to be an issue for all women, because women are different shapes and sizes. But if your standard that you're designing equipment is this male body, this norm, what does that mean for women that are different shapes and sizes, that are smaller, that are typically smaller? And we are seeing like anecdotal evidence on Twitter of women. I saw one story of one female health provider saying she failed 3 fit tests, right? So it's like, not only is their equipment not available, sometimes it doesn't even fit.
Yes, we saw this last year with NASA as well. So this is definitely, there's a history of this issue. Okay, so for the other panelists, if you want to jump in on the other questions Amanda gave, go ahead. Amanda, maybe repeat the questions.
Okay, one question, I'll repeat Peter's question. He said, how can we leverage the coverage of nurses in addressing the pandemic to highlight some of these gender inequities at this time when people are recognizing the importance of this? How do we get society to act on fixing this problem?
Yeah, I would say that it's unfortunate that we would need something like a pandemic to highlight and leverage. And I think the momentum has been building for a long time. And won't be because of what is happening with COVID-19 that we're going to start to see some emergence. I think one of the things that does happen is that we can tend to sort of, I like to think of it as like looking down. And when you're looking down and you're really concentrated on one thing, you start to see the cracks. But those cracks aren't necessarily caused by the reason of you looking down. And I think a lot of times we were maybe looking up and thinking about the aspirational goals and how we can do things. And so this might help to mediate, so that we're sort of thinking about the pragmatic aspects, but along with the more aspirational aspects as well.
Go ahead, Barbara.
Yes, thank you. Of course, Peter has hit on really the crux of this issue. It's how do we fix this? And I think in nursing, we kind of bring this long history of being a profession that has been almost an adjunct profession in its development. It isn't anymore, but we kind of drag that along with us. And I think we have to, in a sense, make the most of what everybody has discovered about nursing through this pandemic. I mean, and it's, as you say, Michelle, awful that it should be through a pandemic like this and lost lives. But I think many people, including nurses, realize how important they are as a team member. Nurses are at every stage of this pandemic. They do the testing, they do community work, they work in ITU, they do palliative care. They're every step along that care chain, you will find a nurse. And we know that, and people who are nurses know that. But I think this is a time to think about how do we take that forward with our colleagues. And I'm very nervous about alienating my male colleagues in nursing who often come to me and say, but what can we do? We want them to speak for all of us too, as we speak for them. We're all nurses, but of course, nurses who are women face different challenges, and indeed, in some of the intersectionality. So I think it's time to speak up and speak out as a profession for what we do and what we've achieved and where we are and how essential we are. And to use the data we have to make those cases. So it goes beyond being emotional to, here's the facts, folks, look at the facts. This is where nurses were, this is what we contributed. and get our colleagues to say it too.
Sorry, I was muted. Jennifer, go ahead.
Yeah, and I'll just chime in and can be quite brief. But, you know, I think just to summarize where we are in this movement, I think nurses need to be part of the global health security conversation, decision-making bodies right now more than ever. You know, we aren't just at the front lines, we are the front lines. We see what's happening live. We see a rapidly evolving pandemic unfold, and we have valuable information and tools to offer, and we have innovations and ideas in order to help not just nurses respond, but all health systems respond.
May I just jump in and very quickly just to answer that question? So, you know, I think I agree with everything that the panelists said, you know, about how do we leverage this time, you know, and I think I have never seen as much attention on sex and gender as I have in the last month or two on social media, in the news, across the, you know, across the board. And I've, you know, my whole life is gender. So what I look at might be quite skewed, the information I'm getting, but I have seen so much attention given to it. And this is, you know, we really have an opportunity right now because we have this sort of shared experience globally. We have, you know, this light being shined on where the cracks are, where the problems are, how can we fix it? And in health systems, we often talk about, especially when thinking about fragile conflict-affected states, humanitarian settings, when a crisis hits, how can we build back better? How can we build systems and structures that are gender equitable? How can we ensure that our health systems are gender equitable, that our health workforce is gender equitable? And we need these sort of windows of opportunity, like what is happening right now, to get that momentum, to make that change, to bring people together, and to develop the policies and procedures that we need. And we really have an opportunity right now to do that, that we should be leveraging.
Thank you so much. And thank you, all of you, for your incredible commentary today. Now we're going to turn to Howard Catton, who will provide closing remarks. Howard is a registered nurse from the United Kingdom and is the Chief Executive Officer of the International Council of Nurses since February 2019. Over to you, Howard.
Sarah, thank you very much. Thank you to the Wilson Centre. Thank you to Jhpiego. Of course, this always happens. You have such a fantastic panel that everything has already been said, hasn't it? So I will try and draw some thoughts together on this, but I think you have heard some excellent contributions. For those of you who don't know, ICN is the body recognised by WHO and the international organisations to represent the voice of nursing. We are 130 national nursing associations strong, and I had the very great pleasure to co-chair the State of the World's Nursing Report along with Baroness Watkins from the Nursing Now campaign and some of the fantastic leaders at WHO. If you look at what's happening with COVID, if you look at what the State of the World's Nursing says, we know that we have a deeply ingrained history of gender inequality, unfair treatment, discrimination. That narrative is the plot line that runs through what we're seeing with COVID and through State of the World's Nursing. And it's stark and it's shocking, but it's also a huge opportunity. Not to repeat all of the statistics that the panel have given, but just to put a few together to just show how shocking this narrative, this plot line of gender inequality is that runs through this contemporary report and COVID-19. Does it say something that this is the first time we've ever had a State of the World's Nursing report? Why have we only had it now? ICN has been tracking and working with our associations on COVID since the beginning of the year, because we had associations in Asia, in Europe, and now talking to those in Africa as well. Some of the statistics which have been reported by governments show infection rates, healthcare infection rates of 9%. We've seen that climb as high as 14% in Spain, sickness rates at 20-25%, and the tragic deaths that we've seen, 3 in the last few days of nurses who were pregnant who have died. But this data is not being collected in a standardized way and reported to WHO. That is as shocking as the fact it's the first time that we've had the report, that it sends the message that it looks as though those staff, overwhelmingly women, are expendable in some way. What measure gets count? It sends the message that these staff, these women, don't count. I think it goes beyond gender. I think if what we're starting to see with some of the Black and ethnic minority issues, we haven't got good enough data there, but it's pointing that there may be some BME issues. Just think about in terms of the people who are being impacted most by COVID through having atypical and insecure employment, poorer, lower socioeconomic groups. So it's an inequalities issues which is being highlighted very, very strongly by COVID. Pandemics exacerbates inequalities, and we are not now doing enough to not only collect the data, but we're not also seeing, I think, strong enough political leadership. ICN wrote in the last few days a letter to the G20 leaders telling them that they needed to do much, much more in relation to what they could do around both the production and the supply and distribution of PPE. And I'll come back to that because I think the advocacy and getting involved in the political space is really important in terms of the next, in terms of our next steps. Just in terms of a couple of the statistics around State of the World's Nursing Report, you've heard panelists talk about 59% of the workforce being nurses and midwives. Yes, the report also highlights that we only currently spend 25% of the education budget globally on 59% of the workforce. What does that say? How shocking is that? What does it say about the deep-rooted inequality? The fact that we have a 6 million shortage. We know that there's maldistribution around the world, but let's just call that over 21% shortage. Which other professions would that be tolerated? Would that be acceptable to have that level of shortage, given what we know that that means for people's work-life balance, stress, pressure, burnout as well? In terms of safety, there's a very stark statistic in the report about only 37% of countries reported having measures in place to protect nurses' safety. It could actually be worse than 37% because it was based on 55 countries reporting. It could be as low as 20%. There are other stats that speak in terms of pay and career progression as well. But put some of those together, it may sound as though I'm doing it in quite a melodramatic way, but I'm doing it on the basis of the evidence. And there's a couple that Barbara and others have mentioned. If this was evidence that Barbara was bringing forward from Nursing Now, if this was evidence that ICM were bringing forward from Nursing Now, people might say, oh, well, it's a snapshot. There's a bit of professional self-interest. You would say that, wouldn't you? This is evidence from a WHO report that's been written and tested to a very high level. But we need to be as smart about our messaging, our communications, the narrative that we want to tell, as well as using the evidence. Here are 2 questions which are keeping me awake at night about everything that's happening, that's going on now. The first is that the report says very, very clearly we need to invest in nursing. It sets out 10 strategic recommendations, but we are heading, are we not, to another global downturn, another economic crash, perhaps even as bad as a depression. How will we get that investment against the backdrop of economic downturn? Question 1. Question 2, we need to recruit and we need to retain people in the workforce. So they're not a big risk that anyone looking at the prospect of coming into nursing at the moment and seeing the negative picture, which I painted with some of the statistics, may actually be put off from coming into the profession. I think we have a serious glass half empty scenario, and by taking the opportunity, we've also got to be really smart about presenting the glass half full scenario. How do we do that? Here are just a a few thoughts picking up on what panelists have said already. First thing is that the report sets out 10 strategic directions. Leslie said that's our roadmap. It is our roadmap. We don't need to reinvent stuff or come up with other stuff. Take those 10 recommendations, get them in your country CNO's strategic plans. We need to work with WHO that they form the bedrock of the next strategic plan for nursing and midwifery from WHO as well. We know that we've got shortage, and that means both recruiting and retaining. Let's think about how we might leverage and argue that in perhaps some slightly different ways. Here's an example. Barbara talked about the Prime Minister of the UK, Boris Johnson, his COVID experience, and he mentioned 2 nurses. Fantastic. Barbara said that he mentioned 2 nurses. The 2 nurses he mentioned, one is from New Zealand, one is from Portugal. They're not trained, they're not educated in the UK. By his own words, he seems to be highlighting that the UK has not been self-sufficient in the supply of its own nurses. And if it hasn't been, where has it looked for nurses? From countries that can least afford it. You then see it just exacerbates the issues of maldistribution. Let's not be frightened as well about talking about the need for nurses to have a pay rise, not as some reward to COVID, but because it is a serious policy lever to both recruitment and retention. The leadership piece, I think, is absolutely key. I would urge a word of caution on the 70% in the report about countries that have CNOs. ICN did a report at the beginning of the year where we asked similar questions, and we also found that people would say 70%, but if you dig down a little bit and say, is that person really a nurse? Have they got a nursing qualification, midwifery qualification? Does that person have a budget? Where do they sit in the hierarchy? Actually, it might be closer to 50% of countries who have chief nurses at the level that we would want. The advanced nursing practice piece has been mentioned a couple of times. Massive, massive solution. Let's frame it as a solution. The report, again, the WHO evidence-based report says these roles evaluate well in terms of clinical outcomes. Patients like them as well. They're care effective, but they're also cost effective as well. We should be seeing health services designed and built much, much more around advanced nurse practice roles, nurse-led clinics. Yes, if you look at where they're most prevalent, it's where there are medical shortages, and actually the medical profession have even more issues with aging than nursing does as well. Just today, ICN has got a new publication out on advanced nursing practice, which I'd available on the website, which I'd commend to you to you all. The way in which we do some of these things, though, and a number of speakers have talked about looking outward, not inward, which I absolutely support and endorse. But I think what many of us have also seen from nursing is that we've seen the tribes within nursing, the educators, the regulators, the associations, the government nurses, the provider nurses, splintering. And I think that sometimes we've made it really easy for politicians not to do what we say, do what we ask, to accept our arguments. Because say, oh, you say that from the association, but the chief nurse thinks this, the regulator thinks this, the educator thinks this. One of the fabulous things Barbara's and Lord Crisp's campaign around nursing now has done has started to bring people together, and we need to build on that. And then the final point for me is, Michelle really started to open this up well for us, to think about the money. And of course, we all know the line around nursing, think about it as an investment, not as a cost. But if we look at what's happening with coronavirus at the moment, is there any, and others have said, nobody would have wanted this to have happened, but it is our current reality, and it is showing just how intimately related our health and well-being is with our economic well-being, how our lack of preparedness and investment in health is going to leave us with is leaving us with infection rates and deaths now, is leaving us with a period of perhaps 12 to 18 months before we find a vaccine is leaving us without even the personal freedoms to go for a walk in the park. So, you know, there's a line in there about invest in nurses so you can go for a walk in the park and go and see your elderly relatives on their birthdays as well. I'm not being flippant about it, but yes, I think there are different ways that we need to think about how we make the money argument, because it is going to be really, really, really tough. When we move past the clapping and the applause, we want to see the action, we want to see the commitments, but it would probably be against one of the most challenging economic backdrops that we've known for tens or hundreds of years. So through all of that, the coming together, the advocacy, the campaigning, not being frightened to get in the political space, the voices that many nurses have had as a result of COVID, the exposure, the fabulous articulation I've seen from both frontline nurses through to chief nursing officers. We need to build and we need to capitalize on that. And perhaps just to keep reminding ourselves that actually, without a bit of pressure, we rarely get any progress, and that needs some cohesion, it needs some campaigning, it needs not to be frightened of advocacy and getting in front of some microphones and TV screens as well. Sarah, thank you very much.
Yes, thank you. Thank you so much, Howard. And I think some of those points you brought out, we really need a second panel of discussion. And I know that there will be more events coming out from other organizations too, talking about these very important issues. For us at the Maternal Health Initiative, we do have an event in 2 weeks on COVID-19 and both gender and racial inequities. So that'll be on April 30th. So please come back and join us again. For now, just thank you so much to all of the panelists for all of your commentary. I really look forward to keeping in touch with all of you and really appreciate you taking the time to be here today. Thank you to my colleagues at the Wilson Center and also my colleagues and friends at JPIGO. And most importantly, thank you to the world's 28 million nurses. Thank you all.
Thank you.